So next we have Artemis Tsavaliangos Petropoulou from University of California, Los Angeles, talking about alterations in functional network dynamics following ketamine treatment in major depression. Thank you.
Great, thank you so much. So I'm a postdoc with Catherine Nara at the University of California, Los Angeles. I'll be giving this talk on behalf of Brandon Taraku, who's a very talented research assistant slash incoming graduate student. I'll do my best to answer any questions that you may have, but I was not quite as in the weeds in the analysis as he was, so I'll provide his email at the end of the slides so you can contact him further if I can't answer your questions. So neither of us have anything to disclose. I think we're all familiar at this point that major depression is a highly prevalent and heterogeneous disorder. As beautifully illustrated in Chai et al., fMRI studies have shown that depression is characterized by disturbances across a wide range of functional brain networks, often associated with cognitive and emotional processes. So ketamine treatment has gained significant attention over the last few decades as a antidepressant. So although it was initially developed as a hospital anesthetic, when administered at a sub-anesthetic dose, it produces rapid and robust antidepressant effects, even in patients who are otherwise treatment resistant. However, the mechanism behind the antidepressant response remains unclear. As illustrated in this figure here, we recently did a review of functional MRI studies, actually multimodal MRI studies looking at the antidepressant effects of ketamine, and we found that for fMRI specifically, it perturbs several different functional networks implicated in depression, such as the central executive network, the default mode network, the salience network, striatum and reward circuitry, and the limbic system. However, majority of these studies have focused on static properties of functional networks, where the average correlation of bold signal at rest is computed across the entire time series. As I'm sure you've heard at several other talks this week, we know that fMRI studies have demonstrated that during rest, patterns of brain activity experience dynamic fluctuations over short periods of time, which may be missed when averaging across the entire time series. So this has motivated the investigation of dynamic functional connectivity in fMRI and has strong potential for providing novel insights into brain networks and how they contribute to the pathophysiology of psychiatric disorders. Not allowed? Okay. So while there are different approaches for investigating brain network functional dynamics, we focused on co-activation pattern analysis, or CAP analysis. This is a data-driven approach for analyzing recurring patterns of brain co-activation over time. We do this by clustering bold time series to find recurring co-activation patterns. And the CAP metrics computed using these brain states include the frequency of CAP, so the amount of time spent in one CAP state relative to the whole time series, mean dwell time, which is the average amount of time a CAP state persists without changing states, and transition probability, which is the likelihood of transitioning from one state to another. So CAP has been well utilized across several cross-sectional studies of depression, showing disturbances in dwell time and transitions between resting state networks specific to depression, as well as associations between altered resting state dynamics and rumination. It has great potential for exploring antidepressant treatment outcomes, but has not yet been well examined longitudinally. Really just, okay. So the overall goal of the study is to understand how ketamine treatment affects resting state functional dynamics, and to do this, we performed a CAP analysis on a group of patients with treatment-resistant depression undergoing antidepressant ketamine treatment. So for the study, treatment resistance was defined as unresponsive to at least 2 antidepressant treatments. These patients underwent serial ketamine treatment, so they received 4 infusions of racemic ketamine over the course of 2 weeks. Resting state fMRI was collected at baseline and 24 hours after their 4th infusion. 54 healthy controls were collected at baseline, and although they did not receive ketamine treatment, 18 healthy controls had data collected 2 weeks later, so within that same longitudinal window as the patients. Clinical assessments were collected both pre and post-treatment, including the Hamilton Depression Rating Scale and the Rumination Response Scale. Imaging data was preprocessed using the human connectome minimal preprocessing pipeline, and then further denoising with global signal regression and bandpass filtering. The Schaefer-7 network parcellation NTN subcortical atlas was used to create an atlas of 454 ROIs, and bold time series were z-scored for each ROI to get normalized bold signal activation and deactivation. So the CAP analysis was performed by running K-means clustering in MATLAB using all subjects to find time points with similar patterns of co-activation and co-deactivation. The elbow criteria was used to determine the optimal number of clusters, and CAP metrics included frequency of CAP, mean dwell time, and transition probability. For statistical analyses, we used paired sample t-tests to look at longitudinal changes pre and post-treatment. We looked at associations between change in CAP metric and improvements in mood scores using Pearson's correlation. And for significant results, we performed follow-up analyses looking at baseline comparisons between patients and healthy controls using independent sample t-tests, controlling for age and sex, and all analyses were corrected for multiple comparisons using Bonferroni. So ketamine worked very well. We saw significant improvements in overall depressive symptoms, as well as 2 domains of rumination, including brooding and reflection. So 6 CAP states were found to represent the optimal number of clusters based on the elbow criterion. The colors here represent Z-scores to show the relative strength of activation, so hotter colors, or deactivation in cooler colors across brain network nodes. You can read more about the individual states in the manuscript, but for the sake of time, I'll highlight the few that we found specifically interesting in our results. State 1 is characterized by activation of the visual network. State 5 is predominantly characterized by the activation in the salience network, and state 6 for predominantly the central executive network. So here you'll see significant changes over time, showing the different states, as well as box plots indicating the change. The gray are the healthy controls for reference. So I bring your attention to this box here. We see significant decrease in the fraction of time spent in the visual network. However, at baseline, there was no significant difference between cases and controls, although they tended to trend higher, and so we do see this decrease towards the values of healthy controls. In fraction of time spent in the central executive network, we saw a significant increase. At baseline, patients were significantly lower than healthy controls, so it does seem like ketamine is restoring this fraction of time, increasing this fraction of time spent in the central executive network. We saw a significant decrease in the transition probability from the salience network to the visual network. And again, at baseline, there was a significant, patients showed significantly higher transition probability, and this seemed to normalize towards the values of healthy controls with ketamine treatment. And finally, we saw a significant increase in transition probability between the salience network and the central executive network. And again, we did have a baseline difference in healthy controls, and it does seem to normalize. So in terms of correlations with behavioral scores, percent improvement in reflective rumination was significantly correlated with decreases in the fraction of time spent in the salience network state. In baseline, there was a significant difference between patients and controls, where patients spent higher fraction of time in the salience network. So it does seem to be that this decrease in time in the salience network may be contributing to the improvements in rumination that we see. So overall, we saw that ketamine antidepressant treatment affects network dynamics between the salience network, the visual network, and the central executive network. The visual network change shows consistency with prior ketamine studies. We see it keep popping up across various fMRI studies, suggesting ketamine may be targeting the visual network. We saw significant increases in the occurrence of the central executive network, which also is common across fMRI studies, suggesting that ketamine treatment may be restoring the typically hypoactive central executive network that we observe in depression. We also saw changes in transition state from the salience network, so salience to visual and salience to central executive network. This may be so basically it suggests the salience network may be driving the changes of the occurrence of these networks, which seems to be consistent with prior studies that have found that the salience network plays an important role in dynamic switching between brain networks. As I mentioned previously, the decrease in the occurrence of the salience network was significantly correlated with improvements in rumination, and there are prior CAP studies that have found significant correlations between CAP states involving the salience network and rumination. And overall, we saw cross-sectional results suggested that the observed longitudinal changes tended to normalize towards levels of healthy controls. So some limitations, this was not a randomized clinical trial. There was no placebo. However, the CAP metrics remain stable in the healthy controls who were scanned twice, suggesting that the changes that we did see in the patients may be attributed to the ketamine treatment. Another limitation of the CAP methods is that the identification of specific clusters to identify brain states can differ across studies, but we did see correspondence with prior CAP studies, and we also found that using different clusters, so K-1 or K+1, we did find similar brain states, and the results remained significant. And so finally, all of this impressive work is a culmination of a year's worth of hard work done by first author Brandon Taraku. Again, this is his email address. Brandon would like to thank his colleagues in Dr. Catherine Nar's lab and Dr. Lucina Udin's lab, specifically Jason Nomi, who was critical in setting up the methods. And on a final note, Dr. Nar is looking to hire a postdoc, so if you're interested in psychiatric interventions and brain imaging and would like to join us in Los Angeles, please reach out. Thanks.
Thank you so much, Artemis. Perfect. We have a question in the room.
Thank you so much. Very interesting talk. So about placebo, you said there was no placebo. I've got basically two questions. First, did the subjects know what the research question was? And second, if there had been a placebo, what do you think its effect would have been? Thanks.
Yeah, thanks so much. So this is a question we talk about all the time. This was a naturalistic design, so patients were undergoing ketamine treatment regardless. So I guess they were expecting to hopefully feel better, but not necessarily about, they weren't informed about any kind of brain network changes that we would be looking into. In terms of placebo, it's so tricky because what is a ketamine placebo? Right, so there are some studies that use midazolam that can make the patients feel a bit woozy, but to actually get a real placebo that's convincing is really hard. In terms of what we would expect to see, maybe the effects of ketamine are placebo, but they seem to be working. If it is a placebo, it's a really good placebo, right? Because these are patients who are treatment resistant, so nothing else has worked. In terms of what we would see brain imaging-wise, I'm actually not sure, but if you'd like to email Brandon, maybe he can give you his thoughts.
I think that's all the time we have, but thank you so much, Artemis.
Okay, so I don't know if Janik Alterman has come here, but apparently it's a no-show. We don't have a video either, so if he's not here, then we'll wrap it up, and thank you all for coming.